mics.
Okay, welcome everybody. Just before we kick things off, I'll just highlight some of the upcoming talks we have. We have the Lauren Cohen Yale Giant Lecture coming up next week. We have our very own Dr. Frampton the following week, and then some further fellow talks after this. So please join us. Okay. So to start, I'd like to introduce our first fellow talk of the year. We have Dr. Michael Fury, who's currently a second-year cardiology fellow here at Yale. He graduated from Georgetown University School of Medicine and was recruited to the Yale IM program in 2019. His academic excellence was recognized early when he was awarded the Peggy B. Award for Outstanding Clinical Teaching from the Yale School of Medicine. He completed his internal medicine residency and chief residency at Yale, and then stayed here to complete general cardiology fellowship. He has published over 35 manuscripts in prominent journals such as JACC Heart Fail and the European Heart Journal in the domains of electronic health record implementation to improve heart failure care, disparities in care, biomarkers, and heart failure risk prediction. I've known Michael since residency, and I've always very much enjoyed working with him together on service, and I've always been impressed by his work through our collaboration on numerous research projects, including some current projects which we are just in touch this week. I'll now turn to his co-fellow, Dr. Ali Khan. He is also a second-year cardiology fellow here at Yale. He earned his BS in chemistry with highest distinction at the University of Virginia, where he stayed then to pursue an MD and PhD in biophysics. During his time at UVA, Ali did his PhD research under Dr. Mark Yeager, where he studied the structure and dynamics of gap junction membrane channels, understanding their molecular mechanism in cardiac induction and myocardial infarction. This work was funded by the Ruth R. Kirchstein National Research Service Award from the NIH. Following his MD PhD, Ali completed his medicine internship at the University of Mississippi Medical Center. He then moved to Yale, where he completed the remainder of his residency in IM and subsequently stayed for cardiology fellowship. During both his residency and fellowship, Ali has worked on numerous clinical and basic science research. Under the supervision of Dr. Rachel Lampert, he has explored the impact of atrial fibrillation on athletes and their responses to various treatments. He is also working in the laboratory of Dr. Joel Butterwick, trying to understand the molecular mechanism of class 3 antiarrhythmics with cardiac and potassium channels. His number one job, though, is being a husband and father to his 2 young children. And his next career goal is to become an electrophysiologist and plans to apply for EP fellowship in the upcoming year. There's never a dull moment when you're on service with Ali. He always manages somehow to find the most challenging clinical cases, but he's always a true pleasure to work with, and the patients I know are under the best clinical care. Now I'll hand it over to Dr. Khan to kick things off.
Thank you for the kind introduction. We're honored to have the opportunity to present today's grand rounds. Today, we're going to have a discussion on ICD therapy for primary prevention and heart failure in the current era of guideline-directed medical therapy. We have no disclosures to report. Here are the learning objectives for today's talk. We're going to review key primary prevention ICD trials and current guidelines for patients with heart failure with reduced ejection fraction. We're going to assess the impact of GDMT on the incidence and prevention of sudden cardiac death. We're going to explore ongoing ICD trials and their potential to inform future clinical practice. And we're going to discuss primary prevention guidelines in the context of contemporary GDMT. So first, I'm going to talk about the major ICD trials supporting the placement of primary prevention ICDs in heart failure. Life-threatening ventricular arrhythmias are a significant cause of sudden cardiac death, particularly in patients with reduced ejection fraction. In one study, it was mentioned that sudden cardiac death is 6 to 9 times more likely in patients with heart failure. Implantable cardioverter defibrillators, ICDs, protect against sudden cardiac death by recognizing and cardioverting patients out of fatal ventricular arrhythmias. While ICDs save lives, they're also associated with significant morbidity, and there are also risks of implantation. Since the MADIT-1 trial in 1996, many trials have investigated the impact of primary prevention ICDs in the heart failure population. While we don't have time to discuss all of these trials, I'm going to review some of the main trials that have led to our current guidelines. The MADIT-1 and MADIT-2 trials were the seminal trials that demonstrated the improved survival of ICDs in the post-myocardial infarction population. These trials randomized patients post-MI with a decreased EF and NYHA class 1 to 3 symptoms to ICD or conventional therapy at the time. MADIT-1 randomized patients with an LVEF of less than 35% with documented NSVT and inducible VT on EP study. The MADIT-2 trial randomized individuals with an EF less than 30% without documented or inducible arrhythmia. In both cases, ICDs led to improved survival. In 2005, the sudden cardiac death and heart failure SCEDHEF trial was the main trial that led to approval of primary prevention ICDs in the non-ischemic cardiomyopathy population. This trial enrolled a comparable number of both patients with ischemic cardiomyopathy and non-ischemic cardiomyopathy with NYHA class 2 and 3 symptoms and randomized them to ICD implantation, conventional therapy with amiodarone, or conventional therapy with placebo. ICD therapy showed improved survival compared to both amiodarone and the placebo group. The most recent of these major primary prevention trials was the Danish trial in 2016. This was a study performed at medical centers in Denmark that implanted ICDs, with the exception of ARNIs and SGLT2 inhibitors, which were not available during that time. The trial enrolled non-ischemic cardiomyopathy patients on a guideline-directed medical therapy that's closest to the contemporary GDMT, including ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists, and CRT devices. Interestingly, during the 5.6 median follow-up period, the trial showed a significant decrease in sudden cardiac death, which was a secondary endpoint. But the primary endpoint from death from any cause, there was no significant difference between the ICD and the control group. These results have generated a lot of controversy on the role of primary prevention ICDs in this population. But one major critique of the trial that's worth mentioning is that 58% of the population in both the ICD and control arm had a CRT device, which made it difficult to generalize this trial to non-ischemic cardiomyopathy patients not eligible for CRT. These are the current guidelines from the 2017 guidelines for ICD implantation among cardiomyopathies. The first three are for patients with prior MIs. If there's an LVEF less than or equal to 35%, NYHA class 2 or 3 symptoms, there's a 1A recommendation for ICD implantation. If the EF is less than or equal to 30% with NYHA class 1 symptoms, it's also a 1A recommendation. Having a decreased LVEF less than 40% with NSVT due to prior MI and inducible sustained ventricular arrhythmia at EP study is a 1B recommendation. And the last two recommendations are for non-ischemic cardiomyopathy. So an LVEF less than 35%, NYHA class 2 or 3 symptoms is a 1A recommendation. Class 1 symptoms in an EF less than 35% is a 2B recommendation. Based on expert consensus, all of these guidelines come with the caveat that patients would be on maximum tolerated GDMT for at least 3 months and greater than 1 year life expectancy. The 3-month period is to allow for LV improvement. And we're going to be discussing this sort of 3-month period a little further today.
All right, so now that we've reviewed some of the trials that informed our initial understanding of ICD benefits, I'd like to talk a little bit about the development of GDMT and its impact on risk for sudden cardiac death. So the development of our medical therapies to improve outcomes in heart failure have been the result of decades of innovation and investigation, starting in the 1980s, establishing through the consensus trial that enalapril improves benefits or improves mortality for heart failure patients, progressing through the years where beta blockers, angiotensin receptor blockers, as well as mineralocorticoid receptor antagonists shown to improve outcomes as well. We fast forward to 2014, where the paradigm trial established the benefit of sacubitril valsartan. And then in 2019, the SGLT2 inhibitors first showed promise for treatment of heart failure patients. So now the standard of care for patients with heart failure and reduced ejection fraction is quadruple therapy with beta blockers, SGLT2 inhibitors, mineralocorticoid receptor antagonists, and RAS inhibitors, either sacubitril valsartan, an angiotensin receptor blocker, or ACE inhibitor. The unfortunate reality is we've had significant difficulty implementing these therapies for our heart failure patients. And the most jarring recognition of this was demonstrated in this 2018 study using data from the CHAMP-HF registry, which tracks patients with chronic heart failures throughout centers across the United States. And at this time, there were only 3 available therapies as the SGLT2 inhibitors had not yet come to market. But nevertheless, fewer than 25% of patients were on all 3 classes of medicine, and the majority were titrated to a suboptimal dose. And perhaps most disappointing, only 1% of patients who were receiving all 3 therapies at their full target dosing. This is data from a more recent analysis in 2024, looking at 30,000 patients who were hospitalized with heart failure. And it showed that 15% of patients were prescribed quadruple therapy, and 41% of patients were prescribed triple therapy with a RAS inhibitor, beta blocker, or mineralocorticoid receptor antagonist. And this is despite over 93% of the patients that were evaluated being eligible for triple therapy. So to summarize, we've made some progress since the initial 2018 study, but we still have quite a long way to go. And we know that GDMT for heart failure confers a substantial mortality benefit, but how does it impact the risk for sudden cardiac death specifically? These are some data from recent heart failure trials where the incidence of sudden cardiac death when it was reported as an endpoint are plotted for the GDMT therapy compared with placebo. And you could see in some of these bars, there's some of the individual components, the beta blockers, the SGLT2 inhibitors, and Entresto all showed a significant reduction in risk for sudden cardiac death, while others such as valsartan or eplerenone did not exhibit the same effect. And we don't know for sure whether the components of quadruple therapy, when taken together, confer an additive or even a synergistic benefit in the reduction of cardiac death or sudden cardiac death. But there's a few studies that I'll show now that might point towards a potential benefit like this. This was a study from 2022 that looked at individual components of GDMT as well as those components taken in combination, and showed a drastic improvement in overall mortality as well as cardiovascular mortality when these agents were taken together, which might imply that risk for sudden cardiac death is lower when these agents are taken together. And there's another study of patients who already had an ICD or a CRTD published in JACC EP a couple years ago that looked at how patients fared based on the number of GDMT agents they were prescribed. And it showed, unsurprisingly, that those who were on 3 or 4 of the agents in quadruple therapy had a substantial survival benefit compared with those taking 1 or none. In addition, and I think it was important, they looked at the number of patients who experienced their ICD firing over a 2-year study period. And those who were on more of the GDMT agents actually had 50% fewer ICD shocks. So given some of these outcome benefits of GDMT that we just discussed, I think it's important to try to tie together how some of the seminal ICD trials fit with our current understanding of GDMT. So it may seem obvious, but for those trials that took place in the 1990s, the 2000s, up till 2016, those patients were not able to take sacubitril valsartan or our SGLT2 inhibitors because they were not yet available therapies. But based on some of the data we've reviewed thus far, we think they would have a substantial benefit in reduction of sudden cardiac death. Of note also, there are some disparities in the prescribing patterns between some of the earlier trials, specifically the beta blockers and ACE inhibitors in the MADE-IT trial. And then broadly speaking, the use of triple therapy was relatively low in across these trials, given that we've come to know more and more over the years about the substantial benefits of GDMT. And furthermore, this is another interesting figure looking at how risk for sudden cardiac death across the trials over the years. In some of those initial trials, there was a very substantial reduction, 23% in the 96 MADE-IT trial, up to the more recent Danish trial, 2016, the risk reduction conferred by ICD was reduced to 2%. So Ali mentioned that the 3-month sort of window whereby we try to optimize GDMT as much as possible for our patients prior to considering ICD. Here are some data from the PROVE-HF study, which might signal that that window is a little bit short. So this was a mechanistic study to try to figure out why sacubitril valsartan has such a substantial impact on outcomes for patients with heart failure. These were patients who were already prescribed a good background of GDMT and assessed their biomarker response as well as some cardiac remodeling parameters with echocardiography to try to figure out how Entresto helps heart failure patients. And this specific data presented was a sub-study that assessed patients who were ICD eligible at the beginning of the trial. And on the left graph, we're looking at the LVEF at 6 months after starting sacubitril valsartan, on the right, 12 months. And this study specifically found that by 6 months, 32% of the patients who were initially eligible for an ICD were no longer eligible because their ejection fraction had increased to greater than 35%. And that number increased even further to 12 months, by 12 months to 62%. So, this made us wonder whether that 3-month window should be reconsidered or extended to potentially up to a year.
This next part, we're going to discuss our proposed approach to primary ICD placement in the context of contemporary GDMT and the importance of using shared decision-making. Michael summed up the effect of GDMT, reducing sudden cardiac death. But despite GDMT, there's still residual risk of sudden cardiac death. This is a circulation review which measures the residual risk of sudden cardiac death from some of the major HF trials. In red, the most recent Paradigm HF trial was studied in Entresto and DAPA HF, which looked at dapagliflozin. And in these trials, even in these most recent trials, the risk of sudden cardiac death was greater than 2.5%. With that said, there's no consensus at the moment about what's an acceptable level of sudden cardiac death risk. But as a frame of reference, if we look at the hypertrophic cardiomyopathy population, which has its own set of guidelines, but they have from the European Society, they have a 2A recommendation if the risk of sudden cardiac death is greater than 1.2% per year. Now, given this residual risk, it's important to try to identify and risk stratify patients who will benefit with an ICD beyond just the LVEF. But this has proved to be very, very challenging. Various electrical measures have been looked at in the past, such as T-wave alternans, signal average ECG, and EP studies, and they've not quite shown adequate discriminatory power to separate higher risk and lower risk individuals. Risk scores have been developed from specific cohorts, but there's a question of how generalizable they are, and there's no consensus on how reliable they are. Needless to say, there's a need to identify phenotypes that would benefit from ICD implantation. And what I'm going to try to do in the next few slides is to identify certain factors that affects risk of sudden cardiac death and propose how we can implement these into our practice to better risk stratify patients for ICD implantation. The first factor to consider is the etiology of the patient's cardiomyopathy. This is because certain cardiomyopathies by nature are arrhythmogenic. This includes, some of these conditions includes ARVC, familial cardiomyopathies with arrhythmogenic phenotypes, channelopathies, hypertrophic cardiomyopathy, sarcoid. And again, due to the nature of these diseases, if there's a patient that's presenting with a newly decreased EF, and it's important to rule in or rule out some of these phenotypes because they, and if they're ruled in, implantation earlier would be favored. Another important factor to consider is the likelihood of reverse remodeling. If a patient presents with a low ejection fraction from an irreversible cause, such as multiple MIs or an infiltrative cardiomyopathy with significant irreversible scar and fibrosis, they'll likely benefit from an earlier implantation of an ICD because their chance of EF recovery is so low. In addition, myocardial fibrosis increases the risk of sudden cardiac death. This is an illustration from a retrospective cohort study that included about 1,100 patients with dilated cardiomyopathy, looking at the risk of ventricular arrhythmias and sudden cardiac death based on ejection fraction and the presence of late gadolinium enhancement on cardiac MRI. This study showed that patients that had LGE present with an EF less than 35% were associated with like the highest event rate of sudden cardiac death at about 7.2%. The other side of it, if a patient did not have LGE and had an EF greater than 20%, this actually had the lowest risk of an adverse event rate. They also nicely showed that there are certain distributions of LGE that are more rhythmogenic than others, and in particular the mid-wall. And these sort of, if you have LG in these high distribution areas, it can just in itself increase someone's risk to intermediate. So given this data, we believe that LGE should be factored into decision-making regarding timing of ICD placement. Now, in the absence of the risk factors that I mentioned, we believe that waiting for EF recovery beyond the 3-month threshold is appropriate. Michael showed data that showed that the improvement of EF can extend beyond the 3 months on contemporary GDMT. And by allowing the EF to occur, that's a way of reducing the risk of sudden cardiac death in itself. These are some numbers that are shown here. This one was from a observational Japanese study that showed a 1% increase in LVEF is associated with a 22% decrease in sudden cardiac death. Closer to home, there's a analysis of the DAPA-HF trial showed that per 5% increase of LVEF is associated with a 14% risk in sudden cardiac death. Given sort of this, we really, we want, if patients have low risk, we think giving them adequate time to recover their EF, we can protect this population from unnecessary implants of unnecessary device implants and risks of device implant-related complications. Michael and I will be even more bold to say that maybe this 3-month threshold in the low risk population should be more than, the threshold maybe should be set at a year. This was from the data that Michael presented before. I've also put here the Kaplan-Meier curve from the SCED-HF trial. And as you can see, even the mortality curves here, they start to deviate at about 18 months, which suggests that it is reasonable to suggest that it gives support to waiting longer.
So beyond the left ventricular ejection fraction, there are a few significant risk factors that we think should also be definitely considered as decisions are made about ICD implantation. Age is the first one. The survival benefit that ICDs confer in patients that are over the age of 65 may actually be decreased. There have been studies that showed 1/3 of patients who got an ICD that are over the age of 65 die within 3 years of implant, likely from other comorbidities in this patient population. And frailty and dementia are also significant risk factors that should be considered, specifically because there's twice the mortality rate for patients who have those comorbidities and get an ICD. ICDs, it's not entirely clear how they benefit patients with ESRD. These patients were actually not included in the original trials. And patients who require hemodialysis have a 23% mortality rate within the first year after getting an ICD. They have higher complication rates, and they often die from other causes than a ventricular tachyarrhythmia. A lot of our cardiomyopathy patients have atrial fibrillation or recurrent supraventricular tachycardia, which may increase the risk of an inappropriate shock. However, over the years, the devices have become more sophisticated with their programming and are more able to discern between an appropriate or inappropriate shock delivery. But nevertheless, we would recommend strongly towards a shared decision-making approach that highlights for the patient what we know about the survival benefits of ICDs in the context of their own individual risk profile, as complications of the device and their overall goals of care. One under-recognized impact of ICDs is actually psychological impacts. I was surprised to learn that up to 15% of patients report that they have a difficult emotional adjustment after they get their device, regardless of whether it's provided a shock delivery to them. Among those patients who do have an event and require a shock, 33% of them report very significant psychological distress. They suffer potentially from PTSD and fear of getting additional shocks in the future. And some even choose to deactivate their device after they experience such an event. And patients may ultimately experience other quality of life issues, experiencing depression or fear. So these should all be considered in counseling our patients when providing these therapies. And this is a slide I wanted to include to better quantify, how often these devices are providing shocks to patients. This was from 2024, over a 10-year follow-up period. They found that the annualized risk of a device appropriately shocking was 1 to 2%. That risk is, driven a lot by patients who have certain phenotypes and are much more likely to have a recurrent shock. This study had a secondary aim of identifying the clinical variables that would predispose patients to a first or recurrent shock. And to the author's surprise, they weren't able to elucidate, consistent clinical variables, which speaks to our point that it's extremely difficult to, restratify these patients and counsel them, and speaks to the need for future studies into risk factors. One tool that we think it's important to know about is the Colorado Shared Decision-Making Tool, which helps with the process of discussing ICD placement with our patients. It's a 8-page file that includes pertinent information about the devices, presents frequently asked questions, as well as space for patients to reflect on their thoughts about ICDs, as well as space to write down questions that they have about them, and encourages patients to bring these forms to their visits with their providers to make the most informed decisions about ICDs. So given everything we've discussed this far, we wanted to go through a pathway by which we try to identify those patients who would be most benefit from an early ICD implantation versus those who it might be reasonable to clinically monitor over time. For patients who have an EF under 35 with significant LGE on cardiac MRI, in addition to any of these listed inherited or infiltrative cardiomyopathies, we'd recommend early ICD implant, ideally within 3 months of diagnosis, because these patients are at the highest risk of sudden cardiac death. For those who don't fit one of those higher risk phenotypes, we'd recommend optimizing GDMT for 3 months as per the current guidelines, potentially obtaining a cardiac MRI to further characterize presence of LGE. And for certain individuals, specifically those who have a very low ejection fraction under 20%, or who have a presence of significant LGE, or those who have significant ischemia, either a recent MI or at extremely high risk for future ischemic events, we would recommend pursuing ICD therapy. We would also recommend if patients are unable to tolerate additional GDMT additions or titrations, and who are unlikely generally to have recovery in their EF, they could be considered for early ICD implant also. And finally, in the red box on the right-hand side, for those who have been optimized on GDMT, and there's improvement in the LVEF from baseline, but not quite at 35%, or they lack significant LGE on cardiac MRI, we would consider extending that watching period to further optimize GDMT and assess for recovery or improvement in EF every 3 months. And I wanted to highlight a few ongoing trials that will help us as we with our risk stratification of these patients. The ProFit ICD trials being conducted in the European Union. And this is actually looking at post-MI patients to assess how prophylactic ICD implantation, assess whether it's beneficial for these patients who are being treated with contemporary GDMT. The CMR ICD trial is based out of Germany, and it will enroll patients with non-ischemic cardiomyopathy, as well as fibrosis on cardiac MRI, and assess outcomes in this patient population. The TRACER ICD trial is actually an observational trial that should be completed shortly. That's looking at outcomes for patients who got an ICD who are over the age of 65 to better characterize their outcomes, and will help us better understand how quality of life is impacted for this group. And finally, the CONTEMPT ICD trial is looking at both ischemic and non-ischemic cardiomyopathy patients who are thought to be of low arrhythmic risk, randomized to an optimal GDMT regimen versus ICD plus optimal GDMT.
In 2025, it's hard to give a talk without mentioning artificial intelligence. Artificial intelligence has revolutionized our ability to find patterns in complex, high-dimensional data. In this challenging field of risk stratification for sudden cardiac death, it has the potential, we believe, of like combining all the risk factors that we've discussed today, including data from the electronic health record, imaging findings, ECG, EP studies, and genetic data to help develop personalized risk prediction for sudden cardiac death. Abstracts have already started to be presented at meetings discussing algorithms to prevent sudden cardiac death. I'm also going to make mention of recent work done here at Yale by my mentor, Rachel Lampert, Cynthia Brandt, and Matthew Berg and colleagues, who developed a machine learning algorithm incorporating demographic data, arrhythmia, and physiological data from ICDs, medications, and clinical history from the electronic health record to predict all-cause mortality, death, and HF hospitalizations. I believe it's safe to say that more is to come in from this space, and I'm hoping that the future will be able to best risk stratify our patients. To conclude, we demonstrated that primary prevention ICDs and GDMT significantly reduce sudden cardiac death in patients with heart failure, which reduces ejection fraction. Current guidelines recommend ICD for patients with an LVEF less than 35% and minimum of 3 months on optimal GDMT. Risk stratification of patients for ICD and modern GDMT is now well studied. The etiology of cardiomyopathy and the likelihood of reverse remodeling influences the risk of sudden cardiac death. We propose that patients with few risk factors of sudden cardiac death with reversible etiology undergo watchful waiting beyond a year. And shared decision-making should be employed as future trials aim to better counsel patients and revise guideline recommendations.
We just wanted to give a quick thank you to our families for all of their support, and we couldn't do what we do without them, as well as Catherine Clark, Alan Enriquez for serving as our mentors for this grand rounds, and to the entire section for giving us the opportunity to speak today. Thank you.
Thank you, Michael. And thank you, Michael and Lily. I know it's an important topic, and just the recent issue of the Journal of Cardiac Failure highlighted this whole topic. So I appreciate the update. Now, any questions?
So very well done and nice summary of a complex topic. I mean, I think it's one of these, unusual situations where the absolute risk reduction of the population and the relative risk reduction of the therapy may be changing at the same time at different rates. So it behooves us to kind of try to get in front of it in terms of our guidelines a bit. You mentioned the issue at the end in your of the ability to titrate GDMT, and I've heard from Steve Green's analyses over the years that we do well. Though doing better, we're not fully aware. So could you explain a little bit more about what you would propose as a kind of marker, a clinical risk marker of GDMT utilization, and how that we might want to integrate that in our decision making a little bit? For sudden death.
Thank you. I think it's first important to speak on the point of why our utilization is so low. The idea of clinical inertia has come up over and over again, specifically that, clinicians, either through, lack of knowledge or, deferring decision-making, to those who are, potentially deemed responsible, i.e. cardiologists or, PCPs, et cetera, as well as some of the financial issues that can accompany, make it costly for patients to afford these medicines and take them regularly. As far as I know, there's been some scales that have been published about like creating a combination score about the number of therapies that are used, as well as, the percentage it is towards, maximal target heart rate dosing or optimal dosing for the patient. I think one of the issues with that is, I think target therapy is a little bit different for everyone. So if, there's an older patient who's quite frail, their blood pressure is borderline, their renal function isn't, completely normal, that's a different sort of target than, a patient who's younger, more robust, and none of the other comorbidities. So I think there's definitely a lot of room to go with that area. And I'm not, entirely sure how we can create like a uniform, marker for that. But I think through continued education and research, and trying to create, to sort of circumvent the inertia that we have, we can definitely make continued improvements in that area.
Thanks, Catherine. A couple of thoughts. Just one minor point I just wanted to point out. For a lot of the cardiomyopathies like ARVC and HCM, we actually put in ICDs and people with what would otherwise be considered normal EFs. And so it's really not an EF is really not part of the risk assessment for those cardiomyopathies. But I wanted to point out a bigger issue, which is that for some reason that I've never totally understood, we tend to think about ICDs for some reason in a very different way than we think about most other therapies. And I'm going to give you one example based on one of the statistics that you showed. 33% of people over 65 with ICDs die within 3 years. Okay, so does that mean we shouldn't put them in? Well, with only that statistic, if 66% of patients over 65 without an ICD of that same population died, we would all be signing up. Do you know what I mean? That could be improving, that could be improving life, improving mortality immensely. So we don't really know. And sort of along those, based on that's not really an argument against it. And again, and sort of similarly, if you had a cancer therapy where 33% died within 3 years, that might be the greatest thing ever. And so that'd be on the front page of the New York Times for some cancers. And so I think that for some reason, we tend to take a harsher view towards ICDs having to sort of prove themselves against these pot shots that aren't really rational in the way we look at therapies in general. So obviously I have a strong bias. I believe in ICDs. I put them in for many years, but I really do think that we think differently about mortality benefit from ICD than we do for mortality benefit for lots of other therapies.
Thanks. Good job, guys. Complicated topic. Couple questions. One is you did, besides ARVC and certain sarcomere mutation cardiomyopathies, that you did highlight the inverse correlation between EF and the risk of sudden cardiac death. And I think I saw the number something like for a 5% increase in EF with treatment, there's a 14% reduction or something like that in sudden cardiac death. But I wonder for somebody, and I've never really thought about this, for somebody who presents with a dilated cardiomyopathy, idiopathic, improves on GDMT, comes in at, 25% EF, and EF goes up to 50% on GDMT or whatever, something close to normal. We wouldn't put an ICD in the patient at that point. But does that risk ever go back to someone who never had an EF down at 20 or 25%? I mean, is that risk gone? Does that individual at that point look like somebody who's always had an EF of 50 or 55%? I never really thought about that.
So what I would say is like it's hard to do, well, it's hard to always make that assessment, even like the residual risk that I showed in the trials. Some of those patients had ICDs that were in the treatment arm. So the risk of sudden cardiac death never goes back. I don't know of any numbers that say that there's like from the observational trials we have like with LG, you can see that sort of based on like that phenotype, it would seem like they have fewer events if their EFs are higher. But I don't know any per se if it goes back to the same. Now, I think that I will go back to the idea of fibrosis, that if that's, if you have recovery, but you still have fibrosis, especially in a high risk distribution, I think that, that risk is not completely gone away. Yeah. But it's probably still better than if, your EF was lower than before. Sure.
I mean, maybe the AI algorithms will eventually sort that out, which is a segue to my second question. I didn't see that JACC paper. So is there a magic algorithm for prediction? I mean, the title looked like there is, but you didn't, you showed the paper.
Yeah.
A lot of focus on that was actually on physical activity and sort of identifying So it wasn't really risk prediction for sudden death.
Okay. Okay. Thank
And
you.
I'll just sort of make one comment about, because the reason that we brought up sort of the high-risk phenotype with the arrhythmogenic cardiomyopathy is definitely endorsing that they're kind of their own population. They have their own sets of guidelines. The reason we brought it is because a lot of our patients, just we'll see them with a newly decreased EF. So that's why we wanted to bring up that, especially that population. We want to at least rule in and rule out pretty quickly that they don't fall into that phenotype, because if they do, then even by guidelines, we have to implant those patients quicker than we would other patients with an EF less than 35.
Maybe one maybe final comment. So in the post-MI literature, I know we've used these cutoffs based on matted and what have you, but in analysis that, are now quite dated, but, basically in the early 2000s, what we were able to define was at a population-based level in post-MI patients, the greatest risk as a population of sudden deaths are actually, there are more patients who are going to die of sudden death who leave the hospital with heart failure and EFs that are preserved. It's just based on just pure numbers. There's more of them. The risk may be lower than the lower EF patients, but because there's so many more of them, the population risk is much higher. So it just also relates to, I'm also a big believer in ICDs as well, Rachel, but it relates to the fact that the technology may be moving at a pace that if we were to able, at a lower upfront cost and risk, we might be able to make more of a population-based level impact by implanting these devices, if they could be done, again, safely, without risk, at a much lower cost, in a larger population of patients who have, residual LGE in the non-ischemic population, or have even EFs that take them out of the group, but still identify, scar and risk. So I think that's maybe where this field might be going, as devices and their ability to implant them and the risk of implanting them goes down. So, but more to come.
Yeah, if I could just make one comment in terms of the shared decision-making, which, no one can ever argue against, to do the shared decision-making. But, this is a particularly difficult one, because you kind of look at that Colorado scale, and the first one is, pro ICD is you're less likely to die when you put an ICD, and the con was, I don't even know what it said, but, right there, you're going to get a lot of people to stop. But, here we are in this conversation, but really to tell somebody, well, you have a 2 in 100 chance of this, or 1 in 100, we can't even tell them. I mean, you can give them a number, but any number you give them is pretty, far off. And so you can tell that however you present it to the patient, 90% of the time you can get them to get what you think you're going to have. So just kind of pointing out that shared decision making is great, but it is really going to depend upon how you present it.
Good job, Dylan. Thank you. Thank you. You just. Thank you. Thanks for your help.
Thank
you
you.
so much.
Yeah. Actually,